it easier for me to just email it to you?
The thing is, I have to get an adapter that we'll use for the port there. I'll just go into the office and get it. So you can still use your laptop, that's fine.
Okay.
Yeah. We're just setting up the stream.
Is this a different connection to the?
Yeah, I think so. I'll just set up the live stream.
Okay, cool. I'm Saul. Machida. Good to meet you. Oh, cool. Good to meet you. I'm a bit sick.
You sick?
Yeah,
Really?
it's head cold. It's serious.
Oh, thank you for coming still.
No, I'm sure. I'm just going to be blowing my nose in between talking. That's all. Yeah. So what's your role here?
I'm still an intern.
Intern.
Yeah.
At LA?
Yeah.
Oh, you can intern here too?
Sorry?
You can intern at LA?
Yeah. You can. So yeah, I started in August.
Okay. What is your role as an intern? Do everything?
Oh, I'm in the AC unit.
Okay.
So like with the aerobic therapy as well.
Okay. Cool. Okay.
Just helping everyone else.
Cool. Enjoying it?
Yeah. It's okay.
Yeah. It's only okay.
It's
Boring.
no, it's not boring.
Why is it only okay?
Well, it's not exactly what I expected.
What did you say?
So just management. So it was just something for me to do.
Oh, cool.
In the meantime.
Okay. Cool. Yeah,
Students should be coming.
that's cool. Trying to get my presentation onto the screen. I've got some slides, but I don't even have to use them really. Just see what everyone wants to talk about.
Yes.
Have you been to some of these before?
Sorry?
Have you been to some of these before?
No, I haven't. It's the first one. Still cutting.
That's no problem.
Switch back, no stop down. Tem lista tá bom. Não existe, não existe. Yeah, I didn't like it. This way goes
messed up with my computer. Down here. Oh, so there we go. It's HDMI. Plug it in there.
Okay, I'll speak anyway. I'll just use this.
So you got another computer?
This is mine.
Oh, okay.
Thanks. Should be on. How's this thing here? Should be USB LAN.
Let me connect directly to port here.
Oh yeah, just do that.
It was not connected to the wall.
Is that right? Yeah, that'll help. Let's try it again. There we go. Thanks. Should we? What is this thing for? Just recording.
It's a requirement for streaming.
Who are you streaming it to?
So other people will be watching, like students will come.
Okay. Did they actually listen? Did they actually watch it?
Yes, they do.
Move this up. Can I start? I think Ruby said I must wait a few minutes. So wait a few minutes. Start. Say again. Lewis. Here.
Okay, good evening, everyone.
Hi.
So my name is Lois, and I'm a second year student from Kenya, and I'm particularly interested in healthcare policies and how they influence the different sectors of healthcare, and that's something that I'm looking to do in the future and the field that I'm looking to go into. And so now, to introduce our guest speaker for today. So today we have Mr. Saul Kornick. He is the co-founder and CEO of HealthForce, an augmentation of technology and doctors that turns nurse-led clinics into specialist health centers. HealthForce has provided over 65,000 telemedicine doctor consultations since inception, and it's now the largest provider of such services on the continent. HealthForce's vision is to re-engineer the way healthcare provision is delivered to all Africans, leveraging technologies and carefully crafted doctor networks. I could go on and on about the amazing work he's done and he's continuing to do, but I don't want to take up all the time. So without further ado, I'll introduce our guest speaker for today, Saul Kornick.
Thanks, Lewis. That's quite cool. Is that an ALA thing? That I'm just getting old. I don't know how these things go nowadays. It's quite a small group, which is quite cool. We can just have more of a discussion. I've prepared some slides. I can tell you a number of different kinds of stories. But can we just quickly go maybe around the room just so I can know who you are and what your particular interest is, if that's okay? Because it will help me in the conversation. Do you want to start?
Sure.
Yeah.
Good evening.
Good evening.
My name is Sun Chang. I'm a second year student from Cameroon, and I'm interested in health economics.
Health economics. Cool.
Hi, I'm Elena, and I'm a Catalyst student, so I'm studying abroad here from the United States, and I'm interested in the intersection of healthcare and business.
Oh, hi. I'm Joseph. I'm from Tanzania University student. I'm actually interested in health and how to manipulate technology to solve those problems.
Should I go again?
Hey, Lewis, yeah.
Okay, so my name is Lois, and I'm from Kenya, and I'm a second year student, and I'm interested about healthcare policies and how they can be implemented effectively rather than just being there but not being.
Hi, my name is Cedric, and I wouldn't say I have a particularly interest in all that. I mean, I'm interested in medicine, but then I wouldn't know how to point out that.
Point out what, sir?
Point out what field exactly.
Okay. Okay. Cool.
I'm Imani, a first-year student from DRC. I'm interested in healthcare and pharmacology.
I'm Tabang,
Hi,
South
Tom.
African. I'm interested in medical research and international relations.
Cool.
I'm Dennis, a single air. I'm from Kenya. I'm a first year student. I'm interested in both technology and medicine.
Cool. Names.
Well, I'm Chido.
Chido.
From Zen.
here watching.
I'm Ms. Rumi Gondo, a health policy expert.
Cool.
I'm Sally, I'm a counselor here, and I'm also interested in the health field and what happens there.
Cool. Okay. And my name is Saul. I don't know whether to stand or sit. It's like such a small room. I just lean on a table or something. Yeah, I've been working in healthcare for, what's it now? 13, 14 years. I actually didn't study anything to do with healthcare. I studied finance, I did a postgrad in machine learning, and I worked for some banks, and was pretty disillusioned with making rich people richer. So I decided I've either got to make myself rich, or I've got to help people who don't have. And took the latter route and started a non-profit organization called Africa Health Placements in 2006. And we placed doctors from all around the world in various African countries, in rural areas and underserved areas. We placed around 4,200 doctors, served around 34 million people, but found it to be quite frustrating. Should I close it? Yeah. Okay, just push the door against it. Maybe that's why the chair. There we go. Yeah, pretty frustrating trying to move human beings around the world to deliver healthcare. That's the problem with my door closing mechanism. Because you had to pack up their lives and move to a hospital in some rural area, and the patients presented very late because they didn't have access to the primary health care they needed, and it was too costly to access care at a hospital. And also the model just wasn't scalable. We were donor funded, and I'd gone into the non-profit space mainly because I was disillusioned with the capitalist world, where the focus was on an ultimate objective of making money. And then got disillusioned with the donor-funded world, where the ultimate objective seemed to be distracted by things like the politics and the people and the processes, rather than the focusing on the purpose for which the organization existed. I've tried to work as hard as I could to keep AHP focused, but that world is it's a hard world to keep people focused in. I suppose it's a hard world to keep anyone focused in. So it was a natural transition for me to move into something where I could still help people get care from a doctor, but in a much more easy to access, low cost, and high quality way. And that's what Health Force is. And I'll tell you a little bit about what it is a bit later. I've got some slides here. I'll go through them so you've got a sense of what it's about, but I'd much prefer, as I'm going through it, that you ask questions and distract the conversation in any direction you choose. Of course, we should start by looking at, so you've got a sense of what Health Force is about. So the need is quite clear in terms of access to doctors. This is a map of the world where the size of the country changes in relation to the statistic being measured. So here you can see there's a big swirl. This is a measuring HIV burden in the world. So you can see a big swirl in Africa and a big swirl in India. As a proxy for disease burden, that's pretty much how it looks. Africa carries 25% of the global disease burden. But if you look at the distribution of physicians, it looks completely the inverse. You've got no doctors where they're needed and lots of doctors where they're not really needed. That's called the inverse care law. It was coined by some guy called Hart in 1971, and it basically means doctors go to where they're needed the least. And it's resulting in a situation in most African countries where there's a big disease burden but not a lot of doctors, because they can't train doctors, they can't retain doctors, they can't attract doctors, whereas a wealthy country like Sweden can train doctors, they've got a lower disease burden, and they can keep the doctors there. So it makes sense that there's something like an inverse care law. Does that make sense? Cool. In South Africa, people often think, oh, but South Africa is different to the rest of the continent. It is different in South Africa for a small group of people, but it's actually the same in South Africa for the vast majority of people. This is the number of people who access private versus public sector in the country. You've got around 16% of the people who are privileged enough to access private sector, but you've actually got 73% of the doctors working in that sector, which means that only 27% of our doctors are serving the vast majority, 84% of the people. It's really no better in South Africa. So there's a massive inequality, and we see this inequality in healthcare within countries and between countries all around the world. In my days at AHP, we used to travel around to rural hospitals. This was a newly built rural hospital in rural Eastern Cape. And the outpatient department here is empty. Can anyone guess why? Why would the outpatient department be empty? Why are there no patients there? Actually, this hospital is a government hospital, so they can access healthcare for pretty much for free. And this hospital is surrounded by a number of homesteads. There's actually a catchment area around, I think, 150 or 200,000 people around this hospital, all within walking distance. Yes, that's right. So there's a lot of people living around there. What's the point of going to the hospital if there's no doctor to see you? They'd rather walk 30, 40 kilometers to a clinic where they know there is a doctor, where there is some staff. This is a hospital in the Northwest Province. You can see the gates to the hospital in the background. And in the foreground, you can see people are actually moving their homes to this hospital, to the gates of this hospital. That speaks to the frequency with which they need access to healthcare. It speaks to the cost of access to healthcare. When you go out to rural South African hospitals, and many other hospitals I've been to around the continent, people are walking to hospital with a blanket because they know they'll be queuing for 2 days to see a doctor, and so they'll need to sleep on the grounds of the hospital overnight. And so it makes sense to actually move your house to the gate of the hospital. Before I go on, I just want to, that's the distribution of doctors that I'm talking about. The overview, I'm talking specifically about the South African healthcare system today as a proxy for many other issues that are going on in healthcare around the world. And the reality in South Africa today is you've got essentially two healthcare delivery mechanisms. You've got the government sector, which is supposedly a system, but a system only in name. It's really very dysfunctional. There are a couple of individuals working as hard as possible in various hospitals and various clinics to deliver care, but there's no real system supporting them. On the other hand, you've got a private sector, which is incredibly expensive because it's hospital-centric and doctor-centric around specialists. So, if you're wealthy in South Africa and you're the privileged few that can access the private sector, if your child has the sniffles, you go straight to the pediatrician. So we've got this weird healthcare system in South Africa, one where there's a dysfunctional, non-existent system delivering to most of the people, and then this parallel system, the private system, it's very specialized, very hospital-centric, it's very expensive as a result. So what I want to describe to you today is a way that we can see a system, what I'm seeing at the moment is a system arising between those two, a new mode of delivering care, and it's enabled by technology. So what a modern functional system needs to look like is, the first thing it needs to recognize is that technology won't deliver care to people. Technology can't care for a human being. Human beings care for human beings. There may be a time in the future where technology will be advanced enough and people will be enough to engage with technology as a health provider on its own, but we are very far away from that date if it ever arrives. We're people, and when we feel sick, we don't just want the rational medicines and the diagnosis. We want someone to tell us it's going to be okay. We want someone to tell us, don't worry, you'll get better in a week's time, this is not serious. If you're a guy and you've got flu, you know man flu is the worst thing you can have. You're going to die, you're never going to make it. Care comes from human beings. So the reality is where there's no health worker, there's no healthcare delivery. That's okay. So this paints a bit of a picture of how a healthcare system could look. And then to explain to you how Health Force is trying to make this happen. So, your traditional points of entry into a healthcare system for the vast majority of people in South Africa and around the continent is you go and see a nurse or maybe a pharmacist or some kind of mid-level health worker like a clinical associate. That's where most people go, to their local clinic. Then from there, if needed, they should have access to the generalist doctor skills in that consultation, because the nurse's scope of practice is limited. There are also a number of other specialties that have to come together around provision of care for children, for adults, for women, and mental health. Really form together a system of community care. If you can have all these skills available to people in any given community, you've got a really excellent early point of access into the healthcare system that can treat pretty much everything before it becomes really expensive and really and time-consuming to access, and also really painful because your disease has now progressed so far that you get into the secondary and tertiary parts of the system. So in Health Force's thinking, this here is what we need to make available for patients. We need to make it available for patients as close to them as possible. In the old days, before the Industrial Revolution, the means of production controlled what you got access to. So if you wanted a shoe, you had to go to a specific cobbler in your village. And if the cobbler made your brand of high heel shoe, great. And if they didn't, well, then you had to have another shoe. With the Industrial Revolution then, we had this whole thing where we could mass produce goods and services. We could transport stuff around the world using fossil fuels. Now you could get a shoe from anywhere in the world. You had factories mass producing shoes. And if you went down to your local store, your local supermarket, you could get whatever shoe was available there. But you were still limited in terms of whatever that supermarket stocked. The world has now moved on from that. We're no longer dictated to by either the producers of goods nor the distributors of goods, but we actually, as consumers, get to choose whatever we want. So you now can go onto Amazon or Loot or Takealot, whatever it is, and you can buy any shoe from anywhere in the world and it will get delivered to your door. And it's the same for many things. Think about the news. In the old days, you wanted the news to go stand in the town square and listen to the town crier. Whatever the town crier told you, that's what you could hear. Later on, there were newspapers, the journalists presented various pieces of news they thought were interesting in a way that they thought the truth looked. And when you read the newspaper, that's what you had access to. Now, you can go online and get any piece of news from anyone, anywhere in the world. Unfortunately, that means you've also got to listen to a whole lot of noise and a whole lot of morons out there too. But nevertheless, you've got access to all of that. And healthcare is going on a similar journey too. In the old days, if you wanted to get access to care, you have to go to the local health worker, the chemist who makes up your medicines, whatever it might have been. We're now currently sitting in a predominantly distribution type model, where if you want access to care, you've got to go to a doctor practice or to a hospital to access the skills for your healthcare. However, there's this wave coming that technology is enabling, as technology has enabled this move in many other industries, to allow the patient, the consumer of healthcare, to choose that service and those skills they want access to without being dictated to by the local distribution point, without being dictated to by whatever doctors in the local GP practice, whatever specialists are at your local hospital. So the current model of delivering care, as I say, is this distribution model where the specialist skills for a doctor sit where the specialist sits. If you want to see a dermatologist, you have to go to where the dermatologist sits. That means that your point of care is determined by where the specialist skills are sitting with the human being. As a patient, you've got to go to that point of care to be able to access it. What Health Force is trying to do is say, well, hold on a second. Can't we make the specialist skill available as close to the patient, the most convenient point of access for the patient, and allow the human being to slot in as needed? So this is what we're doing. What we do is we give clinics, whether it's a nurse, a clinical associate, a pharmacist running the clinic, we give them something called a clinic practice management system on a website that they log into. It allows them to capture a central patient record. It allows them to capture consult information, look at the past consults of a patient, which is great. They can now efficiently manage their practice. But the kicker is when they get to the part of the consultation where they can't diagnose or they can't prescribe and they need access to a doctor, they call up one of the doctors in our network on a telemedicine connection. The doctor on the other side of the telemedicine connection can see the patient and nurse. The patient and nurse can see the doctor up on a screen in the clinic. The doctor can also see the notes the nurse has captured on the practice management system. And from there, a three-way consultation ensues, where the doctor can ask the nurse to do additional physical examinations, medical history, and so on. And with that information, can make a diagnosis and can provide a script, a referral letter, or a sick note on the system so the nurse can print it out for the patient there and then. So at the end of the day, the patient can walk away going, hold on here. I didn't have to go travel around and pay lots of money to find a scarce skill. I felt cared for at my local clinic. So the flow is, the patient walks in, nurse takes the full medical history and does a physical examination, calls up the doctor on a screen, the doctor and the nurse and the patient have a conversation. The doctor provides a diagnosis and a script. The nurse prints the script out for the patient. These clinics are often situated in pharmacies. Goes to the pharmacy, the patient goes to the dispensary and collects the medication, and off they go happily. Simple as. So what that means now is that your local clinic is now a local health center. We have, at this stage, done over 65,000 telemedicine consults in our system, so we are actually the largest telemedicine provider on the continent right now. If you make it a booking to go and see a GP, when you walk into that GP's office, how long will you wait in the waiting room for? That's pretty good. You've got a good GP. It's running on time. 15 minutes, let's say you've got a really efficient GP, you wait 15 minutes in the waiting room, even though you've made a booking and you arrived on time. Without making a booking, you can go into any clinic we support, and within 3 minutes of the nurse calling the doctor's face is up on the screen. Because it's happening on this platform, we can continually keep track of what the... Yes, please. The shortest wait time is if you just call any doctor who's online at that time. But if you have a child with you and you want to see somebody with a special interest in pediatrics, you can select that. If you speak Xhosa and you want to speak to a Xhosa doctor, then you can wait. You can look for a doctor that speaks your language. If you've previously seen a doctor and the doctor's online, you can wait to see that doctor again. So there are various ways in which you can choose to see a doctor. It just does mean that you wait a little bit longer to see them if they're busy with the patient at the moment, rather than just getting the next doctor who's available.
So the 3 minutes timer is for general conditions?
It's just for the general queue, if you're willing to wait for any available doctor. Whatever doctor answers can see all the previous history of the consultations other doctors have done with you. So it's actually quite a nice continuity of care that happens there too. Because it's happening on a digital platform, we're keeping track of the patient's experiences, and our doctors are being rated 4.9 out of 5. We're open 7 days a week, so now you don't have to go to the emergency room on a Saturday because your doctor is closed. You don't have to go to the emergency room in the evening because your doctor is closed. And as I say, we speak 10 languages fluently on the system right now, including French and Arabic and a few others. Yeah. It's not just colds and flu that we're dealing with either. Here you can see the kinds of diseases we're dealing with. It's all sorts of chronic diseases like hypertension and diabetes, serious conditions like respiratory tract infections, UTIs, STDs, HIV, all that sort of thing is being dealt with in the system. There's actually a lot you can deal with over a telemedicine connection if there's a nurse in the room to do the physical examination. We've also got integrated devices so the doctor can get the information that they need. So there's, I think, out of the 65,000 doctor consults we've done, 4.5% have been referred to a physical doctor, but over 95% are dealt with there and then, which is a pretty good ratio. So the current kind of model for accessing care, if you are wealthy enough, is the patient goes to the doctor, you pay $400 in South Africa for a doctor. Say again? You found it more. There you go. So it's an average. I mean, I went from the rate that Discovery is reimbursing at, and reimbursing at 410. But yeah, they pay 500, 600 rand as well. Okay, so let's take a conservative 400 rand. Then you've got to go to the pharmacy to collect your medication. So you've got to travel to the doctor, wait in the doctor's rooms. Imagine as a lady, you've got a UTI. You know you need an antibiotic. You're sitting with your legs crossed for 2 days waiting for the appointment to come around with your gynecologist. You walk into the gynecologist's room, she gives you the antibiotic you need. You drive to the pharmacy. The whole thing costs you 2,000 rand for something that you knew what you needed right at the start. Now, this is the kind of, it becomes quite an expensive exercise. However, with the health force journey, the patient goes to see the nurse. If the nurse can solve your problem, if you've got a cold like I do, and there's no antibiotics that you can take for the common cold, the nurse will say, listen, just take some vitamin C, take some antihistamines, go collect it at the pharmacy counter, off you go. So now instead of paying 400, 500 rand, I walk away paying $100. But if the nurse says, no, actually, you've got an infection here, you need to see a doctor, the nurse can call up a doctor on the telemedicine connection. The doctor can provide a script as needed. You go collect the medication, off you go. But even still, because we're using only 5 to 7 minutes of the doctor's time, because the nurse is doing all the fluff at the start, hey, how are you doing? How's your family? How's your children? How are you feeling today? Does the physical examinations, takes your blood pressure and so on. And at the end of the consultation, explains what the script means and what you need to do in terms of adhering to the treatment. The doctor's only needed for like 5 minutes to actually come in, do the diagnosis, provide the script, and leave. And so the doctor's cost comes down drastically. So even if you have to call the doctor, it's still significantly cheaper than going to a GP, and of course much more convenient. Further to that, after-hours costs go down because we open 7 days a week. If you treat things early, then you don't end up in the emergency room, you don't end up in hospital either. So there's actually a lot of downstream healthcare costs. 80% of healthcare costs are spent in specialist and hospital care. 80%. So early detection, prevention, and treatment can prevent all of that from happening.
Does health force only give support to public clinics?
No. At the moment, we are in 70 clinics. They're all small clinics. They're clinics and little independent pharmacies that serve cash-paying customers. We're busy rolling out the Dis-Chem at the moment. So we'll be in some major big stores as well. And the ultimate objective for us, though, is to serve the 42 million South Africans and other people. We don't just see ourselves being limited to South Africa. We want to serve the 42 million South Africans who don't have access to care. So in order to do that, we need to be able to build something that works. We need to prove it works at scale. And then one of two things will happen. Either NHI will come in, and NHI will say, cool, we're going to buy services for primary healthcare, and our network of clinics will be a place where NHI will then buy primary healthcare services. That's one way we can deliver to those people. The second way is to actually implement it in government clinics. The government moves slowly. They've got their plans. Even NHI, they're talking about 20, 30-year rollout. So we just need to get something that works now, show them it works, and give them the idea of what can be done as they conceptualize this NHI story.
So, how do you get to recruit the doctors to make sure you need the best doctor to provide the best healthcare?
Yeah, it's not an easy thing to do. But I really do have a cold, so just excuse me sniffing and wiping my nose. So the doctors actually really enjoy practicing in the system. They earn more because although they paid less per consult, they're doing more consults per hour because they spend so short a time in the consultation. They also like it because there's no overheads and there's no administration. They can work from home. We actually had reverse bush doctors the other day. We had one of our doctors who went on holiday to the bush, set up his laptop outside his tent, and consulted to patients in the city. The doctors really like it, and we've got a long wait list of doctors who want to join. So right now, as we stand, it's actually very easy to get doctors into the system. despite the fact that there's a shortage of doctors in South Africa, GPs in South Africa are struggling to make a living. There's not enough, there are not enough people who can afford medical scheme cover and cash and paying for care in cash there are too many doctors to service that small group of people in South Africa. And it's a shrinking group of people as well, because people are becoming less and less wealthy. Medical scheme cover, number of people in medical schemes is actually coming down every year. So this actually gives them a source for a stable income too. The problem is going to be as we get bigger. As we get bigger, suddenly it's going to be, health force is, taking some of our, is controlling how we practice, or is taking some of the money from our consultations, stealing our money, whatever it might be. So we're actually busy redesigning the way the doctor network scales. We want to set it up in such a way that the doctors feel like they're sharing in the value created by this telemedicine system, that their interests are aligned with the healthcare of patients, a kind of a value-based model, value-based care, and that they feel like there's a real opportunity to work as a team when practicing on health force. As a team with each other, but also as a team with the nurse and with the other specialties which we'll bring on. And if we can get those three things right, then we'll have quite an awesome platform that doctors will want to plug into and practice on. Because they'll make a good living, they'll work as a team, they'll care for patients, and they'll share in the value created. Right, let me move on from this one. So give you a quick story and then I'll take a pause. This is a guy living on, 60-year-old man. He lives in rural Limpopo, in Leboa. He was covered head to toe in a rash. Didn't want to go to the government clinic because it was a 3-hour queue to see a nurse. There wasn't even a doctor there. So he came into a clinic which was enabled by Health Force. Nurse took a look at him and said, got no idea what's going on here. So decided to use the Health Force system to get him access to care. When we're building all the services we build in Health Force, we try to make it patient-centric. And to make it patient-centric, there's these 5 things that have to happen every time. There's got to be a connection with the patient, understanding the rational and emotional need. There's got to be a real diagnosis and analysis. You've got to inform the patient so that they know what's going on. You've got to deliver the care that's needed, and you've got to continually learn to improve the next time. So the first thing that the nurse did is connected with the doctor on the system. Doctor's face popped up. GP sitting in Cape Town said, hold on, I don't actually know what this is. Let's take some pictures and send it away. So the nurse plugged in this otoscope that she can use on the computer. She plugged it in. She took some pictures, sent the pictures to a dermatology group in America. The dermatologist in America said, this is definitely pemphigus. The GP in South Africa concurred and decided to prescribe the medication for pemphigus. The next day, the guy's condition was already better. Within a month, it was completely gone. At the same time, throughout that whole process, we were getting feedback from the nurse, the doctor, and the patient as to how that experience was going. So this man never left Leboa. He saw a GP, he saw a nurse in Leboa, a GP in Cape Town, a dermatologist somewhere in America. Took him 40 minutes, and it cost him 200 Rand. So this is the kind of thing that technology can enable. But again, it's not the technology doing the care. The technology enables the various people to connect with each other remotely to care for the patient that's in front of the nurse. And there still is a human being in front of the nurse, in front of the patient, the nurse, who is able to be the cultural translator and who is able to really put their hands on the patient and care for them. Yeah.
Let's ask some questions and then give prices.
Give prices. Okay, cool.
So, what is a three-way consultation?
Mm.
So a nurse and the patient are in the room, and the doctor is
Correct. So healthcare should be delivered by multidisciplinary teams. It shouldn't be dealt with in these isolated pockets of just the nurse or the GP. So multidisciplinary consultation, in this context, the three-way consultation is the patient, the nurse, and the doctor.
So second question, so to get everyone moving around, how many telemedicine consultation does Health Force do a year? 65,000.
I mean, I can keep going on. I've got more and more slides and whatever else, but I think that I'd like to pause there and see how you guys want to steer the conversation from here. This is an example of the way technology can enable healthcare delivery. It gives you a sense of where careers in health might go as well. There's always going to be a role for a health worker. You just may practice in a different way. So as a doctor in 10 or 20 years, you may be sitting in your home delivering care. Equally, if you're not a health worker, there's a lot you can do in terms of facilitating the connection and managing the system and building the system around the healthcare workers. But over to you guys. If you guide me as to where you want to go from here.
Okay, I get that you started in finance and you witnessed all of these people lacking doctors in the public sector. But I just want to understand, if you can say, like, how did you end up coming up with this company? What inspired you? How did you go about doing that?
So when I was doing before, for a start, of moving doctors physically just seemed like a lot of work for not enough reward. So being able to connect doctors remotely without needing them to move and using less of their time and getting them closer to the patients for earlier treatment and diagnosis seemed to make a lot of sense. I mean, you definitely do get entrepreneurs in the world, people who have ideas and start them up and go for it. But I very much doubt there's ever an entrepreneur that does it all themselves. There's this idea that when you start something, you've started it. This idea came from a pharmacy group that was testing out whether they could connect a doctor through Skype. There were broader ideas that were built around that. There were various people that contributed towards it. The idea became evolved over time to become what it is now. And I suppose my job as one of the founders was to make a coherent organization delivering a single product around all the various pieces of information that were coming in. Passing the pieces of information, like this is not going to work, this is good to include, we should pursue that. But really, this wasn't I can't claim that this is my thing. There's a whole group of people that have been involved in getting it to where it is, and that group will evolve. This thing that we're building here, you'll see in 2-3 years' time in South Africa. Everyone, wealthy or poor, will access telemedicine, access a doctor through telemedicine at a local clinic. And when that happens, sure, we've seeded it, but there are a lot of other people now building functionality like this as well. And this is the stepping stone towards creating that full community healthcare experience and leading into secondary and tertiary care. So I know that Chris likes the idea of the cathedral. I'm assuming you guys still. This is cathedral building, right? So there's a few stones I've laid, there's a few stones my team have laid, but this is the foundations for fundamentally changing a healthcare system. Not a broken government system, not a system where you've got to go straight to a specialist or a hospital, but rather a system that's as close to the patient as possible, that makes the skills available as early and as close to the patient as possible, so that we can keep that person healthy irrespective of how much money they've got. And there's a long journey to completely re-engineer that system. Yeah.
So, how do you attract nurses to work in this kind of environment? Because
So one of the things in terms of building this new healthcare system, as I say, we're only placing a few of the bricks, a few of the stones. We don't hire the nurses. We don't build the clinics. We use existing infrastructure. So we go out and find a nurse who is in a clinic who isn't enabled through these kind of skills, and we set her up to deliver. There is an important piece here, which is making sure the nurse is the right kind of nurse to collaborate with the doctor, has the appropriate skills, has the basic computer skills to actually operate the system. But there are actually a lot of really competent nurses out there who have a strong sense of purpose in delivering care, who really appreciate the ability the system gives them. Whenever we're using the equipment we use in the clinic is stuff you can buy off the shelf at your local shop. There's nothing fancy that gets put in there. It's a laptop, it's a TV, it's some cabling, it's a webcam. If the clinic can't afford all of that, then we help finance it for them. So we ask them to pay a small amount, and then we charge them a license fee, like a cell phone contract, to recoup that over time. If they can afford to pay it up front, they pay it up front and install it themselves. If they can't install it themselves, we come and install it for them. So it really depends on the situation we find the clinic in. We've really tried to make the setup as simple and as commonly available as possible so that it doesn't become a barrier to entry. Healthforce has been a company that's been running for 22 months. But there was a precursor to Healthforce where we were testing this service out in a pharmacy chain called Medicare. So we did some virtual consultations in Medicare, got the basic technology working, checked the business model behind it, checked patients wanted to use it, checked doctors wanted to use it, checked nurses wanted to use it, and then we scrapped that and rebuilt it from scratch. So the system that's being used today is off the back of the lessons learned on the first system. So it's kind of this thing where the concept has been in the pipeline for 2.5 years, but really it's only been operating any kind of real effect for the last 20 months. Remember, that's it? Okay. Cool, thanks guys. Excuse me, I'm feeling clogged up, and I hope I was able to project my voice and all that sort of stuff.
We've got a little gift for you. An ALA gift.
Thanks.
So there's a student enterprise called Footprints that provides merchandise.
Yeah.
And this is
Awesome.
from
It's from them.
Yes, yes.
Thank you very much. Thanks for
All right.
Cheers. Thanks very much, guys.
So you can get snacks or, talk to Saul and get your book signed. Is it okay?
Yeah, sure. I'll hang around for a bit if you guys want to chat. It's absolutely no problem.